You're listening to He Said, a Cardiology Board Review Series. No fluff, just facts.
This episode is about ECG changes and acute coronary syndromes, including STEMI. We'll talk about the ST segment, including types of ST segment elevation and depression. Then we'll talk about Q waves and what makes a Q wave significant or insignificant. And then we'll talk about ischemic syndromes such as Sgarbossa ST criteria, Wellen syndrome, and de Winter's tall T waves. Starting with the ST segment. A STEMI is defined by the presence of ST elevation at the J point of at least 0.1 millivolts in at least two contiguous leads. The 1 millimeter requirement for ST elevation in STEMI does not apply to V2 and V3. In leads V2 and V3, in women, it has to be at least 1.5 millimeters of ST elevation. In men 40 years old and above, it has to be at least 2 millimeters of ST elevation. And in men below 40 years of age, it has to be at least 2.5 millimeters of ST elevation. Other concerning signs for STEMI are ST depression and tall R waves in V1 to V3, which would suggest posterior MI, diffuse ST depression or deep T wave inversions, especially in combination with ST elevation and AVR, which taken together could suggest triple vessel disease or left main disease, and new left bundle branch block. The shape of the ST elevation can also offer clues. The ST elevations that are concave up, like the right half of a smiley face, suggest benign early repolarization or pericarditis. ST elevations that are concave down, the right half of a frowny face, suggest myocardial ischemia. ST elevation that is straight upsloping, straight horizontal, or straight downsloping also suggests myocardial ischemia. What about the shape of ST depression? ST depression that is downsloping or straight horizontal suggests myocardial ischemia, whereas ST depression that is upsloping is less likely to be myocardial ischemia, although it is still possible. All acute STEMI warrants reperfusion unless contraindicated by code status, bleeding risk, patient refusal, or other non-reversible condition and limited life expectancy. Resolution of symptoms should not be a reason to delay reperfusion in STEMI, only in NSTEMI. How about reciprocals? The reciprocals for an inferior infarct, which would have ST elevations in 2, 3, and AVF due to RCA occlusion, are ST depressions in 1 and AVL. An LAD occlusion, which can show up as ST elevations in the anterior leads V3 and V4, or septal leads V1 and V2, or anteroseptal leads V1 through V4, has no reciprocals on regular ECG due to the absence of posterior leads. A circumflex occlusion, which can show up as ST elevations in 1, AVL, V5, and V6, should have reciprocal ST depressions in 2, 3, and AVF. A posterior infarct, which is usually from an RPDA occlusion but can sometimes be from an LPDA occlusion, will have no visible ST elevations on regular ECG but should have reciprocal ST depressions in V1 to V4. We should know the territory supplied by each major artery. The RCA supplies the SA node 60% of the time. 40% of the time it's from the left side. RCA also supplies the AV node, bundle of His, RA and RV free wall, and the posterior part of the interventricular septum. The PDA specifically supplies the posterior part of the interventricular septum and the diaphragmatic aspect of the LV, which is the inferior wall plus or minus posterior wall. The LAD supplies the left anterior wall, the anterior part of the interventricular septum, and part of the RV. The circumflex supplies the left atrium, the SA node 40% of the time, and the AV node, and the lateral and posterior walls of the LV. Although the RCA proper supplies only RV structures and the posterior part of the IVS, And RCA occlusion can still affect the LV because the RPDA supplies the inferior wall of the LV and sometimes the posterior wall of the LV. If the posterior wall of the LV is involved, then there will be reciprocal ST depression in V1 and V2. Now let's delve further into ST elevations. In inferior wall MI, how can you figure out if the inferior MI is due to an RCA occlusion or a circumflex occlusion? This is how. ST segment elevation in lead 2 greater than lead 3 suggests occlusion of the circumflex as the culprit vessel. This is particularly true when accompanied by ST segment elevation in 1, AVL, V5, and V6. Meanwhile, ST segment elevation in lead 3 greater than that seen in lead 2 suggests occlusion of the right coronary artery as a culprit vessel. This is particularly true when accompanied by ST segment depression in both leads 1 and AVL. You can further distinguish the site of the RCA occlusion by looking at lead V1. If V1 has ST segment elevation, that suggests a proximal RCA occlusion. If V1 has an isoelectric or depressed ST segment, that suggests a distal RCA occlusion. In inferior wall MI, if the ST segment elevation in lead 3 is greater than lead 2, as mentioned above, then you need to obtain a right-sided ECG to look for RV infarct. Lead V4R, i.e., the ECG with the V4 lead in a right rather than left midclavicular line, is very sensitive for right ventricular infarction. Now, if you see ST depressions in the anterior precordial leads V1 to V4 and sometimes prominent R waves, reciprocal to posterior Q waves, then you need to suspect posterior MI and get posterior ECG leads V7 to V9 done to confirm ST elevation in V7 to V9, which would be caused by a circumflex occlusion, usually a dominant circumflex. In STEMI of the left circumflex artery, posterior leads perform with the lead on the same horizontal plane as V6, but on the posterior axillary line, V7, beneath a scapular angle, V8, and on the paravertebral line, V9, will reveal ST segment elevations in more than 91% of patients with circumflex occlusions, with lead V8 having the highest sensitivity. Whether or not ST segment abnormalities are present in the anterior chest leads or limb leads. ST segment elevation of just more than 0.5 millimeters in any of V7 to V9 is considered diagnostic of infarction in the circumflex distribution. The degree of elevation required for diagnosis is lower in the posterior leads than in the anterior leads because of the increased distance from the myocardium. In a lateral STEMI, the ST elevation in AVL is quite subtle because the QRS voltage in AVL is usually very low, and ST voltage cannot exceed QRS voltage. In fact, sometimes AVL's ST segment may even be isoelectric in a circumflex occlusion, so you have to be careful. On coronary angiography, an obtuse marginal occlusion would be expected from an AVL ST elevation given the high lateral distribution on the ECG. The thrombotic occlusion of the left main coronary artery is often fatal, but if it is a subtotal occlusion, you may see global ST depressions with variable ST elevations in lead V1 and AVR. The conus branch is a branch of the right coronary artery that supplies the right ventricular outflow tract. Depending on its size and location, infarct of the conus branch may produce arrhythmias without significant ST elevations or may produce ST segment elevations in leads V1, V2, or rarely V3. Now, we can move on to talking about the Q wave. Significant Q waves usually represent dead myocardium from prior MI, whereas insignificant Q waves just represent the first part of ventricular depolarization. Decades ago, patients presenting with MI were divided into those experiencing what they called a Q wave MI, roughly corresponding to today's ST elevation MI, and those experiencing a non-Q wave MI, roughly corresponding to today's non-ST elevation MI, based on the evolution of the Q waves over the first few days. At the time, it was thought that Q wave infarctions indicated a transmural infarction, whereas non Q wave infarctions only involved the subendocardial layer. However, modern studies using cardiac MRI showed that the development of Q waves on the ECG is determined more by the size of the infarct territory than by the depth of mural involvement. So let's actually talk about the definitions on ECG. A Q wave is considered significant for MI if it lasts at least 0.03 seconds, that's at least 3/4 of one small box, and is at least 0.1 millivolts deep, that's at least one small box deep. Or if it dips at least 1/3 of the height of the QRS complex, which includes the Q part of the QRS, not just the R part above the ground. But in leads V2 to V3, Q waves are considered significant if it lasts at least 0.02 seconds instead of at least 0.03 seconds. That is at least half of one small box. Insignificant Q waves are often found in 1 AVL and V6 from septal innervation, and these are referred to as septal Qs that are there at baseline. Insignificant Q waves are the following: Q waves isolated to 3, that's benign, and is part of the normal depolarization process due to the vectors in Einthoven's triangle. But if Q waves occur in 2 or AVF, that is usually significant and indicates an inferior MI. Septal Q waves in 1 and AVL are almost always benign. QS waves, that's big Q, big S waves in V1 only, named so because there's no R to break up the Q and the S, and the Q and S just morph into one single dip. Those are considered insignificant Q waves. But if the QS waves extend from V1 to also V2 and V3, then that is considered significant and indicates an anteroseptal MI. So these are very subtle findings. Normally, lead 3 has Q waves, but lead 2 and AVF do not have Q waves, as I mentioned. The septal Q waves we talk about that are benign in 1 and AVL are supposed to be thin and small, whereas the QS waves that are benign in V1 are deep and wide. Normal respiratory variation. The heart may naturally be pushed into a more horizontal position while breathing out and left to hang in a more vertical position while breathing in due to factors such as obesity or ascites. In lead 3, breathing out will have a deep Q wave, and breathing in will have a shallow Q wave. In lead 2, breathing out can make a Q wave appear, breathing in will have no Q wave. Fragmented QRS complexes may have a similar sensitivity and specificity as pathologic Q waves for diagnosing a remote MI. Prior MI causes necrosis and fibrosis of the myocardium, resulting in, quote, islands of viable myocardium interspersed in diseased myocardial tissue. These areas of viable myocardium have slow activation due to partial depolarization and depressed action potential, upstroke velocities. This results in heterogeneous activation of the ventricle and fragmented QRS complexes. Now that we've talked about the ST segment and the Q wave, we will go over some common ischemic syndromes, which some refer to as ischemic equivalents on ECG. First is Sgarbossa's ST criteria for evaluating ischemia and left bundle branch block. A left bundle branch block poses several issues in the evaluation for ischemia on ECG. On one hand, left bundle branch block causes secondary ST-T repolarization changes, including ST elevation in V1 and ST depression in T and T wave inversions in V4 to V6, AVL, and 1. These are all appropriate discordances. On the other hand, a left bundle branch block may mask actual ischemic ST-T changes. In the 1990s, patients with new left bundle branch blocks were uniformly sent to the cath lab to look for coronary artery occlusions, but only a minority of these patients actually had an acute occlusion. Extensive myocardial damage, including a large portion of the distal conduction system, would be required to cause left bundle branch block related ischemia. Therefore, new left bundle branch block is no longer considered a diagnostic indicator that's in isolation for acute MI. Instead, we use Dr. Elena Sgarbossa's criteria for evaluating ischemia in left bundle branch block, whereby at least 3 points suggest ischemia. Concordant ST elevation of at least 1 millimeter in leads with a positive QRS, meaning they are both upward, would give you 5 points. Concordant ST depression of at least 1 millimeter in V1 to V3, meaning they are both downward, would give you 3 points. Excessively discordant ST elevation of at least 5 millimeter in leads with a negative QRS complex, because at least 5 millimeters would be too tall even for the expected ST elevation of left bundle branch block at baseline, would give you 2 points. In 2012, the modified Sgarbossa criteria was introduced by Smith, which showed that the sensitivity and specificity of the Sgarbossa criteria for STEMIs improved by replacing the third original criteria, which was absolute 5 millimeter ST elevation, with a relative proportion, an ST to S ratio of less than negative 0.25, meaning further from 0 than negative 0.25, more negative than negative 0.25. This means that the new third criteria can be used on both upward QRS, downward ST, and downward QRS, upward ST types of discordances. In each lead that has a discordant ST deviation of at least 1 millimeter, the amplitude of the ST deviation is compared to the amplitude of the R or S wave. This has been validated and shown to have a sensitivity of 80% and specificity of 99% compared to the original sensitivity of 20% and specificity of 98%. Apart from the Sgarbossa criteria, there are few other clues to tell ischemia in left bundle branch block, such as the Cabrera sign and the Chapman sign. Both signs have poor sensitivity in the 20s but have high specificity. Both of these indicate all MI, but not current MI, in left bundle branch block. Cabrera's sign is prominent notching of at least 50 milliseconds in duration at the ascending limb of the S wave in V3, V4, or V5. Chapman's sign is prominent notching of at least 50 milliseconds in duration in the ascending limb of the R wave in 1, AVL, or V6. Now we'll move on from Sgarbossa's criteria in left bundle branch block to Wellen syndrome's T waves. Wellen syndrome describes the patient who recently has significant anginal pain in the last 24 to 48 hours, but who are asymptomatic by the time they come to the ED, with minimal troponin elevations, but whose ECG shows the pattern on that signifies critical proximal LAD stenosis that is about to completely close. Although they are chest pain free by the time ECG is obtained, this is deadly because 75% of these patients will go on to develop extensive anterior wall MI in the days to weeks. So they need left heart catheterization. Skip the stress test. On ECG, you will find deep symmetric T wave inversions, which is type 1 in 75% of cases, or positive then negative biphasic T waves, which is type 2 in 25% of cases, in at least V2 to V3, and it may extend to V1 to V6, AVL, and 1. It is possible for type 2 to progress into type 1. Unfortunately, they named it as type 1 is type B and type 2 is type A. So again, type 1, which is type B, refers to deep symmetric T wave inversions at least V2 to V3 and possibly V1 to V6, AVL, and 1. Type 2, which is type A, refers to positive and negative biphasic T waves in at least V2 to V3, which can extend to V1 to V6, AVL, and 1. In addition, the ECG must also show no precordial Q waves to indicate a prior infarct, preserved precordial R wave progression, and ST segments that are only less than 1 millimeter elevated or even isoelectric. That's Wellen syndrome's T waves. Now, we will end with de Winter's tall T waves and ST depressions. The Winter sign, also known as persistent hyperacute T wave syndrome, indicates a critical stenosis of the proximal LAD. In a few hours, it will become a normal STEMI pattern. 2% of STEMIs present this way. ECG of the Winter sign will show tall symmetric T waves and upsloping ST depression of more than 1 millimeter deep at the J point in the precordial leads V1 to V6, especially in V3. Note, this is an exception to the usual rule I mentioned earlier that upsloping type ST depressions are usually non-ischemic. This is also an exception to the usual rule that hyperacute T waves have a short duration. The Winter's tall T waves can persist for hours. Very importantly, you will also see upsloping ST elevation in AVR of at least 1 milliliter or more. None of the precordial leads will have ST elevation. The precordial leads will only have upsloping ST depression. So, as you know, normally we may not make much out of ST elevation and AVR, but with ST elevation and AVR accompanied by these changes, ST depression of at least 1 millimeter deep in the precordial leads V1 to V6, especially V3, that is very concerning for the Winter sign, suggesting a critical stenosis in the LAD that will soon become a normal STEMI pattern. That's all for ECG changes in ACS.
This podcast is intended for qualified healthcare professionals and is designed for training purposes only. These materials should not be used for direct patient care or as a substitute for independent clinical judgment. For more educational content or to submit suggestions, visit www.rehu.com/meded.